يا اخوان،
الو
احنا بنحب نهني الدكتور وائل القشقري، والدكتور وائل القشقري جاي من السعودية اليوم الساعة 7 وطالع الساعة 5، وهو الآن رئيس الرابطة العربية للتداخلات القلبية. يعني محبة فينا ومحبة في الأردن جاي تفضل تحكي لك كلمتين.
الله يحميكم.
أهلا وسهلا فيك.
السلام عليكم ورحمة الله وبركاته. طبعا إذا جيت على الأردن فأنا جاي على بلدي الثاني. شعب مضياف وشعب كريم، ويعني سبورتيف لنا على كل الأوجه والمراحل. أنا ايترين في رش يونيفرسيتي في شيكاغو، وكان لي الفضل الكبير طبعا إنه تدربت مع البروفيسور زياد حجازي أستاذنا وأستاذ الأجيال طبعا، والدكتور البروفيسور يوسف تريند الدكتور زياد وابتعثوا لأمريكا، وإحنا جينا ابتعثنا لأمريكا ودربنا على يد البروفيسور زياد حجازي. لكم فضل كبير علي شخصيا، ولكم كل المودة والاحترام، وبارك لزملائي الدكتور محمود زريق والدكتور رايد عوايشة والدكتور جمال الدباس. إنشاء الرابطة العربية لقسطرة القلب مجهود كبير خلال السنة اللي فاتت قاموا به الزملاء، بالإضافة إلى بقية أعضاء المجلس التأسيسي، الدكتور سمير من فلسطين، والدكتور عبد العزيز القثامي اللي كان معانا ومشي يلحق الطيارة من السعودية، والدكتور فيصل الناصر من السعودية. مجهود كبير لإنشاء هذه الجمعية لخدمة الوطن العربي، توحيد الصف، عمل مخرجات تليق بهذه الأمة العظيمة. حاجة جديدة حنقوم بها بحول الله تعالى، بالإضافة للي إحنا أصلاً بنقوم فيها في أوطاننا. مؤتمر عظيم زي هذا السنوي، الحقيقة أنا أتشرف أن أكون هذه ثالث سنة أندرو دكتور محمود أحضرها، وأيضاً هناك عدة مؤتمرات حضرناها. فيعني أنا ترى يوم 8/2 كنت هون، يعني رايد زعل مني قال لي أبغى أشوفك وما كان في وقت. فمتعلق بالأردن جداً وبأهل الأردن جداً، ولكم مني يعني كل الحب والمودة والتقدير. الله يحميكم. شكراً.
شكرا دكتور وائل. شكرا دكتور وائل. طبعا انت هنا وطنك الثاني وبين اهلك واخوانك، واهلا وسهلا. حنبدا السيشن. عندنا 3 سبيكرز فور ذيس سيشن. برحب بالدكتور مصطفى الجمال ماي كو تشيرمان، وبكل اخوان البانيلست. اول توك عندنا للدكتور ايمن حموده. فور ذا نيكست 20 minutes دكتور ايمن بيحكي على الكرونيك كورونري سيندروم Guidelines, the role of beta blockers. تفضل دكتور ايمن.
مش هاي yes, thank you so much. So you've been hearing a lot about acute coronary syndrome, so it's time to look at the cold cases. Okay, so when you look at the whole Arab world, you see that the pink graph here, the pink part of every column is the cardiovascular disease. So regardless of the size of the population, so in Jordan at the arrow there, you can see that the same thing is the lot of patients, or the commonest cause of death and disability comes from cardiovascular disease. This is from our studies many years ago, and you can see that in STEMI in Jordan, if you look at the blue column, 60% of MI in Jordan are patients who did not reach the age of 55, and 10% are below the age of 40. So the burden is higher than the Western countries. This is a study that we looked at the SMURFless patients. SMURFless are the patients who do not have standard modifiable risk factors: diabetes, hypertension, dyslipidemia, and cigarette smoking. Of 5,540 patients, we've shown that 96% are SMURFs and only 4% are SMURFless. If we add to these 4 risk factors too, which are obesity and lack of physical activity, the number goes down to 1%. So of every 100 Jordanians who come with acute event, you're sure that they have at least one or more of these modifiable risk factors. So CAD, regardless of the risk factors, can present in many phases. Acute coronary syndrome, chronic coronary syndrome, which has replaced the term chronic stable angina, sudden cardiac death, heart failure, and sometimes it's incidental. Some patients come for cholecystectomy, and then digging deep into the history, you can find that they have some cardiovascular disease. So the guidelines, the most recent for chronic coronary syndrome, come from the ESC, and if you look at the number of the pages, it's 122 pages. So in 20 minutes, now it's 19. So I have to go through the steps of dealing with these patients. 4 steps. Initial clinical evaluation of the chest pain, because not every chest pain is cardiovascular. Further cardiac evaluation, and then you have the definite diagnosis of CCS, and finally the management. So step 1 is easy. The tools you have, all of us medical students, to the most recent consultants, is the history and the physical exam. These patients are clinic patients, not ER patients. History, physical, EKG, initial labs, and chest X-ray. And this will take you to one of 2 lines. Either patient has cardiac or non-cardiac chest pain. So this is general clinical evaluation. Step 2 is further clinical cardiac evaluation. Again, you look at what we call the pre-test likelihood of having CAD. A basketball player in the national team who is active, non-smoker, has left shoulder pain, has mostly very, very low risk or pre-test likelihood of having CAD. His dad, who is obese, diabetic smoker with oppressive chest pain when he walks, have very high risk or very high likelihood of having an angina. So it depends on the likelihood, and depending on that, you can say this patient is low risk or low likelihood of having CAD. The other patient has high or intermediate risk of CAD. The third step is when you have the highest suspicion that the patient might have CAD is what tools do you use to have a definitive diagnosis. So the second line of testing is the non-invasive versus invasive testing. And this needs a lot of dwelling on that because it's important. So invasive coronary angiography, this is from the guidelines. Invasive coronary angiography is not, in capital letters, not the right answer here for all comers. Not every chest pain has to go for cath. We use it for severe symptoms, very suggestive, high risk treadmill test finding, ST depression elevation very early, hypotension on the treadmill, and the echo finding of wall motion abnormalities, etc. However, non-invasive strategies these days is a better option, and the tools depend on the local availabilities. Back in the United States, right and left, there were the nuclear testing. Here in Jordan, I guess computed coronary CTA, cCTA, offers full anatomy and physiology evaluation. You can see it can show you a lot of information. Again, this is operator and reader dependent, so you have to choose your center and your reader because it gives you a lot of information. Gives you anatomical and gives you physiologic data. If there is non-obstructive mild disease, you can have moderate disease 50 to 70%, and severe stenosis defined as 70% or more in the epicardial vessels, and the left main is 50 or more. So, and a lot of data recently in the black boxes here showed that experience in interpreting the results correlate with less downstream invasive procedures. The more you read, the more you do, the more you know what are you doing, the less invasive procedures cost-wise and stress-wise for the patient. Should always correlate with the clinical symptoms, okay? You cannot take someone for cath based on a CT with no chest pain, someone is active. If you need more data, again, you can use the same CT for functional testing. So let's take a few examples. This is a 90% lesion in a 50-year-old male who's non-smoker and, who's smoker and has typical chest pain. So the CT shows proximal RCA 95%. So here you have diagnosis of chronic coronary angina, and he will take optimal medical treatment and angioplasty. This is a 40% lesion in a 35-year-old woman with high LDL, but the chest pain is atypical, okay? And there is only coronary plaques. So this is, the diagnosis can be ruled out. And finally, this is a 50% lesion 60-year-old woman with diabetes, very suggestive chest pain, although it's atypical, and we know that women have more atypical symptoms. This patient might need functional testing to correlate these vague symptoms with this borderline lesion. So in addition to the anatomy that we can get from the CT, you can get a lot of physiologic data to know if the patient or the lesion is really producing the ischemia or the pain or not. So non-invasive physiologic testing, we have the FFR by CT scan, the angiography-derived functional flow reserve, which is in good agreement with the invasive one. So when we used only to have the wire during the cath and you measure the gradient, now you have the non-invasive way, and which correlate, by the way, exactly. And this, again, very importantly, will reduce the number of unnecessary procedures. So coronary angiography, routine cath for everyone, angioplasty right and left is not the practice. It's not the good practice. Now, other non-invasive modalities depends on the center, depends where you are. The stress echo, the myocardial perfusion nuclear scans, the CT perfusion imaging, again, this all depends on the availability of the modality that you have in your center. One word of caution, this is in the guidelines, a performance measure, PM, and they have almost 12 of them. PM9 says avoidance of routine periodic testing for stable patients, invasive and non-invasive, only needs an indication. You cannot say for someone with a plaque 40% last year in his LAD and asymptomatic, let's check you again by another CT. So you have to document a reason for restudying, which are number one, unexplained change in the LVAF ejection fraction more than 10%, suspected due to cardiac disease, CAD, not valve or something else, preoperative assessment of high surgical risk, someone who's going for liver transplant, and finally, CAD evaluation for non-coronary heart surgery. Someone is going for valve surgery, you need to know if there is a moderate lesion LAD, which probably can be bypassed at the same time. So when you have someone with angina, by angina we mean someone with typical medical school angina, not atypical chest pain. So there must be a coronary disease behind that, regardless of the anatomy and the physiology. So angina, if you love mechanisms and diseases, what is the origin of chronic coronary syndrome? The angina can come from anatomic or physiologic macrovasculature or microvasculature. So we have four patterns. We have the anatomic macrovasculature, we have the functional macrovasculature, and on the capillary side, you have the anatomic micro and the functional micro. So let's take 4 examples. So this is the anatomic micro that you see almost every day. Everyone did angioplasty on your patients yesterday in the conference here, so this is easy. Atherosclerosis, dissection, SCAD, a bridge, right? These are all anatomy and angina. What is functional macro? Normal looking coronaries, but there is a spasm, and the spasm is easily seen and easily reversed by IC nitroglycerin. So this is normal anatomy, however, there is hypersensitivity of the vessel and spasm. What about the tougher part of the story? Because these are all seen in the angiography. The anatomic micro is, this is very, very interesting. You can see it is in small, you can read it. So you have like inward arterial remodeling, capillary rarefaction, intravascular plugging, and perivascular fibrosis or infiltration. Something we cannot see, but they can be tested in lab or anatomy. So very important. This patient, the third one, has severe chest pain, exactly like someone with the first picture to your left, however, normal coronary. So there is provoked micro capillary anatomical problem. The final variety is the functional micro. Again, there is no anatomy problem. The biopsy is normal if the patient has anatomy or any testing. However, there is impairment of the vasodilatation at the level of the capillaries. There is endothelial dysfunction and or hypertrophy of the vascular smooth muscle cells. They all can give you this pattern of same kind of angina with normal coronaries. So you always have to believe the patient if he has angina, However, the coronaries are normal, so they need to be treated, and the treatment depends on the anatomy and the physiology. So the step 4, what is the management-wise? As every other disease, lifestyle modification, medical treatment, and finally you go for intervention. All right, so lifestyle modification, stopping smoking, and in all of our studies for over 20 years, of every 100 Jordanians with CAD, MI, cabbage, stroke, whatever, of every 100 smokers, which are 70% of the CAD population, 3 out of 10 quit smoking, and 7 continue to smoke until their next MI. Medical treatment, again, this is the diamond of all the medications that you know, beta blockers, the calcium channel blockers, trimetazidine, ranolazine, ivabradine, and nitrates. And everyone has certain place in the guidelines, and this is how the guidelines put them. All right, so gives you 4 steps and give you 5 options. The options here, either standard or you look at 2 variations, 2 things. The heart rate, because of bradycardia versus tachycardia, will dictate what medication do you use, and the LV dysfunction, because definitely there are compelling indication for certain medication for a bradycardic heart failure patient or a tachycardic heart failure patient, etc. So as you can see here, it's a busy slide, but if you look at the beta blockers, they are almost filling this slide every way. And for standard therapy to your left, you can see beta blocker or calcium channel blocker, and then you continue to add more second line, third line, until you reach the good optimal medical treatment and resolution of the ST depression on treadmill test and or chest pain. So in summary, this diagram shows you initial management should include beta blocker and or calcium channel blocker. B, other anti-angina medications, I give them the acronym letter, long-acting nitrates, I for ivabradine, T for trimetazidine, and ranolazine, or it can be added on top of beta blockers and calcium channel blockers. And finally, these 4 medications can be sometimes part of the initial combination therapy in selected patients, like someone who's severely bradycardic and borderline blood pressure. Sometimes they cannot tolerate beta blocker and or calcium channel blocker, but sometimes the angina is severe, so that you can start with beta blocker and one of the third line medication, etc. So when you look at beta blocker versus calcium channel blocker to impact the ischemia burden, this is one of the study on bisoprolol that looked at comparison with nifedipine, and for 2 aims. Number 1, to reduce the total ischemia burden and to reduce the morning and afternoon peaks of the ischemia episodes frequency. So you look, the yellow here is the before treating of bisoprolol, and the red before treating with calcium channel blocker. And these are the minutes of ST depression during the monitor for 24 hours. You can see the medication medicated patient with beta blocker gives you more minutes of less ST depression, which is one marker of less ischemia burden. The other one, as we know, a lot of MIs and events come with early morning surge during the circadian rhythm of the cortisol and the adrenaline sympathetic surge in the early morning hours. You can see if you blunt these medications, and there are 3 known medications in the literature that blunt circadian rhythm: aspirin, statin, and beta blocker. And you can see here clearly the yellow color where the variation of the level of the circadian variation of ischemic episodes, you can blunt it with beta blocker, which is more pronounced than when you use nifedipine. And again here, the event-free survival of the patient. This is a 1-year data that shows that bisoprolol has higher event-free survival compared with Adalat. So final point, we tend to put stents quickly without thinking, symptoms and severity. There are 3 pairs by the guidelines. This is the American guidelines. So we have 3 things. General rule, PCI is the magic answer, might not be the magic answer for all of them. And I'll show you data from the Orbita trial, which shed some light on the value of angioplasty. So patients with chronic coronary syndrome and ongoing angina, despite good medical treatment or optimal medical treatment, early invasive angio and revascularization should be considered to improve symptoms. So this is an important point. It is not first-line therapy. It is not when you start just a small dose beta blocker and a statin. You have, unless of course there are severe symptoms, etc. But for the usual population, you have to try first your medication. PCI, some argue that if I put a stent in a patient in the LAD, I'm giving him a placebo effect. He's happy because he feels that the LAD is now open. And this was the point in the prior studies, the FAME and the ischemia. You cannot rule out placebo effect in these studies because there was no control. So the best thing was the Orbitas 2 study. They were very courageous. Okay, they were criticized, but they have point. So they brought all these patients, continuous chest pain despite optimal medical treatment. They took all of them. Half of them, okay, all of them had a sheath, all of them had coronary angiography, all of them felt like the environment is like starting an angioplasty process, but the only ones who knew whether the patient was in the treatment arm or in the placebo arm was only the interventionary group. When the patient leaves the angioplasty suite to the CCU, and after that, no one knows whether the patient had stent or not. And this was a positive, in meaning that even the patients who had the improvement in their angina symptoms were those who had angioplasty. So this proved that if you have a patient still with ongoing chest pain and you believe that he's been giving the best medication you can give and still having ongoing angina, that here is angina can be relieved by intervention. Again, I'm saying that based on guidelines and because we do not have to treat everyone with this modality, as you know. All right, so in conclusions, chronic coronary angina or chronic coronary syndrome is an important part of the spectrum of atherosclerotic cardiovascular disease. Not all of our work is at night ST elevation. The clinic encounter starts by history and physical exam for the medical students and the residents, and then we use the first line non-invasive tools. We have to determine the pre-test likelihood to help us determine which way to go. Sometimes there is no really good positive pre-test likelihood, so you just don't consume your modalities. You can just do treadmill and send the patient home. And growing evidence of utilization of hs-CTA is really mounting in defining the anatomy and the physiology. And the invasive coronary angiography should not be our daily resolve in these patients. The 3 types of medication or the tiers were lifestyle, antiplatelets, statin, DOACs. Individualize your angina medications based on the side effects, the patient profile. LVEF and heart rate are very important to consider. Revascularization strategy, it has to be indicated in the face of good medical treatment, patient is unresponsive, and you always can quote the Orbita 2 trials. Thank you so much.
شكرا دكتور أيمن. We'll probably questions هلا؟ questions بالآخر؟ Let's leave questions بالآخر. شكرا. ما أنا بالآخر دكتور أيمن. Stick around. Our next speaker دكتور عاصم النماس. أبو أحمد صديقنا, senior consultant interventional cardiologist. We'll be talking about lipid management after acute coronary syndrome.
PCI.
After PCI.
Are we reaching the targets?
Are we reaching the targets?
يعني let's see. مساء الخير جميعا. يعني أنا will talk not only in ACS patient but lipid management in all high risk patients in general. يعني هذا slide shared by Dr. Ayman. يعني cardiovascular disease is the leading cause of death worldwide. In 2019, the global estimated death was 18 million. 1/3 of that constituting 1/3 of global death. In 2016, cardiovascular mortality about 9 million deaths due to ischemic heart disease. Almost half, 55%, were women, were men and 45% men. 2.9 million deaths are due to ischemic stroke, which is considered also cardiovascular disease, 50-50 in men and women, and about 3.3 million are due to hemorrhagic stroke. Risk factors and the number of risk factors plays an important role in risk of developing events. This slide shows the probability, our 10-year probability of having cardiovascular event in a man age 45 years. If you have hypertension, your 10-year probability is about 4%. If you're dyslipidemic, then your probability goes to 10% in addition to hypertension. The more you add in the risk factor, you add diabetes, the probability goes to 14%. Smoker extra goes to 21%. And if you have a previous event, the risk goes to 40%. So the key word here is early intervention or early reduction of your cholesterol. If you control only hypertension and dyslipidemia very early, you would have that probability or that risk by 50% almost. Again, some statistics. The prevalence of dyslipidemia worldwide was 39%. This was in the year 2008. So about 40% of the population are dyslipidemic. And again, when it comes to the cardiovascular disease, the most important risk factor is dyslipidemia. While if you consider the stroke, the most important risk factor is hypertension. We know by controlling high blood pressure, you would reduce the incidence of stroke almost by 50%. If you control dyslipidemia, again, over time, you will reduce the risk of coronary heart disease by almost 50%. So, stroke, always been debatable role of statin in prevention of stroke or reduction of stroke, but the statin trials did show most of them 27 to 29% reduction in stroke by controlling dyslipidemia, while controlling coronary heart disease and death, the coronary heart disease and death were reduced anywhere between 23 to 36%. طبعا اذا بتطلع على كل الستاتين ترايلز يعني البرايمري بريفنشن والسكندري بريفنشن وحتى الاي سي اس وكل الستاتين ترايلز you will find the number ranging from 20 to 35% risk reductions. This is the algorithm adopted by European Society of Cardiology 2019. يعني it seems busy, but it's very easy. If dyslipidemia need to be treated according to guideline, all guidelines agree that high intensity statin is the initial treatment. So first step is you start with maximal tolerated statin, preferably high intensity statin. Then you wait for another 4 to 6 weeks and you check your LDL again, and if the level still is not a target, the recommendation is to add ezetimibe, and you wait another 4 or 6 weeks, and if still is not at a goal, then you add the injectable PCSK9 inhibitors. طيب يعني هذا الدياجرام adopted by European Society of Cardiology, بس يعني you don't need really to follow this diagram 100%. يعني إذا إحنا على maximal tolerated statin وال LDL target is still high, and you know by adding ezetimibe you're going to reduce about 20-25%. If you're not going to reach the target by adding ezetimibe, you can skip ezetimibe and go to PCSK9 inhibitors right away. احنا بنعرف انه ال PCSK9s reduce LDL by about 60%. يعني this is the most potent LDL reduction, حتى more potent than statin. يعني معظم الستاتين بينزلوا حوالي الهاي intensity statin على الماكسيمال دوز ممكن ينزلوا 50%. If you're lucky, you can go to 60%. طيب برضو هذا diagram, you will see it almost in all lipid lectures. And these are the target numbers of LDL, again adopted by European Society of Cardiology or European Society of Atherosclerosis, 2019. Now they considered LDL of 116 milligram is the target for low risk. يعني low risk النمبر تبعهم لازم يكون 116. إذا بتذكروا قبل 20 سنة بدأنا 160 ملغ، بعدين نزلت 130 ملغ بلس additional، والآن صفينا على 116 ملغ على low risk. Low risk meaning يعني they're 10 years risk less than 1%. But you can do the risk score again, calculated risk score less than 1%. Intermediate risk level recommended is 100 mg per deciliter. هذا كان previously number for high risk groups. الآن number for high risk group required number is 70 mg per deciliter. Previously this was optional, now it's a must. And they came with a very high risk group. يعني very high risk group هذولا with atherosclerosis or repeated events within 2 years أو عندهم diabetes with multi-organ damage, then the number should be 55 mg per deciliter. They even came with extremely high risk, they dropped the number to 40s. So LDL is getting lower and lower, and the lower is better, definitely. Just like to remind you some of the guidelines in 2019. As an ACS patient, it's all recommended to be in high intensity statin. It's a class 1A. وزي ما حكينا the LDL goal rechecked in 4 weeks. If it's not at a goal, you add ezetimibe. Again, ezetimibe is a class 1B. And after another 4 weeks, if it's not at a target, you add PCSK9 inhibitors, what is a class 1B. The patient with a history of stroke or TIA, again, these are considered cardiovascular disease, and statin is a 1A. The same goes for chronic kidney disease, for peripheral arterial disease. All these are considered a class 1A for high intensity statins. This is an interesting trial, Sparkle. This is a secondary prevention trial in patients with stroke, aggressive reduction of LDL cholesterol, and they want to see how much you can reduce re-stroke again. And what's interesting about this trial is that atorva 80 milligram reduce the incidence of re-stroke by 20 events per 100 patients. يعني تقريبا 20% reduction in the incidence of stroke. بس في additional benefits. The additional benefits, reduction in coronary heart disease or reduction in peripheral arterial disease. So statin definitely are very beneficial in prevention of cardiovascular and stroke. I'll just remind you of some of the ACS trial. This is probably one of the first trials, Miracle trials. Miracle is a very short-term trial, 16 weeks, يعني about 4 months. High dose atorva or Lipitor for 80 milligram compared to placebo. And you could see very early benefit after 4 weeks almost. Significant reduction in primary endpoints. اللي هي كانت death, non-fatal MI, worsening of angina, and resuscitated cardiac arrest. At 16 weeks, there was 16% relative risk reduction with p-value significant. This was the first ACS trial with high-dose Lipitor. This trial was a short timing. Then we have another trial. This is it's a different trial, Improve It. And Improve It done in Simva 40 versus Simva 40 and ezetimibe. Again, these are patients are stable acute coronary syndrome with LDL less than 125 or less than 100 if prior treatment. يعني قارنوا السمفا 40 alone مع السمفا 40 مع الإيزيتيمايب والفولو اب على 2.5 years. طبعا الترايل is a positive trial وبناء على هذه الترايل الايزيتيمايب was introduced in the guidelines. بس it took some time to show clinical benefits. يعني بينما الاتورفا 80 البنفيت was demonstrated after almost 4 weeks, it took almost 2.5 years to show benefit, but yet it's a positive and introduced ezetimibe in the guideline. Other trial is the TNT. TNT is again secondary prevention trial, treat to new target, Lipitor 80 versus Lipitor 10 in a patient with a stable coronary artery disease. Very large trial, 10,000 patients, 80 ضد العشرة, 22% additional risk reduction in the cardiovascular events. Again, demonstrating high dose in atorvastatin was significant reduction of more events. الآخر trial راح أحكي عنها في الأكيوت كورونري syndrome اللي هي اسمها PROVE-IT TIMI 22. This trial again an ACS trial comparing atorva 80 versus bravastatin 40 milligram. The follow-up was 2.5 years will result again 16% relative risk reduction in MACE or cardiovascular events. What's interesting again, you see curve separates very early, will benefit started as early as first 3 months. So high dose atorva again, early benefit with early interventions. طيب concern about high dose صراحة السايد effects كانت minimal. الانسيدنس of rhabdomyolysis كان قليل 1 to 3 cases in 100,000. Elevation of ALT less than 2%. New onset diabetes in this trial 1 in 255. I think the number is higher than that, new onset diabetes. I'll show you the last slide about new onset diabetes. Right. Few more words about Planet trial comparing atorvastatin with rosuvastatin. Planet 1 and 3, these are patients with chronic kidney disease from stage 3 to stage 5. And they compared again Lipitor 80 milligram versus rosuva 10 and rosuva 40 in these patients with stage 3 to 5 chronic kidney disease. What's interesting about this trial that the decline in the GFR was seen with rosuva high dose 40 in comparison with atorva 80. In atorva 80 there was no decline in the GFR, and the more interesting that atorva demonstrates almost 20 or 25% reduction in proteinuria, while rosuva did not show any effect on proteinuria. Now, both of them are high intensity statin, both of them are recommended as a first line, but few slight differences in between. Here, one of the differences in chronic kidney disease. Also, this is just what I have mentioned, that atorva 80 milligram reduced proteinuria by 24%. The final words about, again, chronic kidney disease. Do you need adjustment with the dose? Some of the drugs you may need to adjust the dose if you have stage 3 to 5 end-stage renal disease. يعني patient advanced chronic kidney disease, you need to adjust most of statin doses. rosuva بدها تنزل ل 20 بدل 40 والأذر حتى البرافاستاتين بدك تنزل الدوز. Atorvastatin, you don't need any dose adjustment with patients with advanced chronic kidney disease. طيب حكينا على موضوع النيو onset diabetes. الفيرست سلايد شوفوا new onset diabetes with high intensity statin after 6 to 8 years of using high intensity statin, the incidence was 20%, يعني much higher than what the number I showed earlier. وفعلا هذا بنشوفه مع مرضانا اللي we follow them for a long period إنه بيكون hemoglobin A1C in the beginning يمكن 5.4 5.8 بعد 5 years بتلاقيه صار 6.5 or even higher. So new onset diabetes increased by 20%. بس بالمقابل reduction in MACE is 30%. فالbenefit outweighs the development of new onset diabetes. يعني هذا ما غير recommendations. This was published in American Journal of Cardiology, statins and new onset diabetes. هسه بشكل عام كل الستاتنز they increase the incidence of new onset diabetes. أخف واحد فيهم على الإطلاق هو البرافاستاتين، يمكن لأنه ووتر سوليبل ستاتين في compared to other بس كمان رزوفا is ووتر سوليبل بس زود الانسيدنس of new onset diabetes. The dose of statin will intensity of statin definitely related to development of new onset diabetes. The more potent is the statin, or the higher the dose, the more likelihood of developing new onset diabetes. I think this was my last slide. Thank you very much.
شكرا دكتور عاصم. Nice presentation. And I'd like to point انه في dedicated study على البيتافاستاتين بالديابيتس was not shown. احنا مرضانا مرات اللي بيكون عندهم مثلا بدهم moderate intensity statin وعندهم family history we default لبيتافاستاتين. بس طبعا atorvastatin has a very long track record we definitely recommend it. We have the third speaker دكتور قيس بلبيسي. دكتور قيس حيحكي على high sensitivity troponin in detecting the myocardial injury in the non-cardiac surgery post-operative أو perioperative period. دكتور قيس associate professor بالجامعة الأردنية وصديق وحبيب وconsultant interventional cardiologist. فخورين بوجوده معنا. دكتور قيس عشان نضل فخورين 20 minutes.
الله يسعدك. Thank you Dr. Iyas for such a great introduction. برضه بحب أشكر دكتور محمود organizing committee for such a great conference. Really a lot of good talks, a lot of good points. I'm very happy to be part of it. All right, so today I'm going to try to talk about a subject that we've been coming across now, kind of more of chronic diseases. But this is also an important point. We might not have paid attention to it as much as we should, which is basically myocardial injury or infarction in non-cardiac surgery and detecting that through the value of high sensitivity troponins. So my talk is going to be a little bit about definitions, pathophysiology, burden, and then we'll talk about troponins in the setting of perioperative myocardial injury. Then we're going to talk about risk stratification and guideline recommendations. All right, so I'll start with a quick case scenario. First, we have a 73-year-old male. He's going for elective surgery for hiatal hernia fundoplication. He's diabetic, on oral medicines, hypertensive, and a smoker. He doesn't complain from any cardiovascular system. He underwent his surgery, which took around 5 hours, and went through a laparoscopic technique, kind of, I don't want to go through the details, but wasn't a simple surgery. Post-operatively, he has no symptoms, his blood pressure is okay, and his preoperative troponin is, the high sensitivity one is 16. On day 1, it becomes 41. Hemoglobin is 8.7, creatinine is 65, NT-proBNP is 95, D-dimer and procalcitonin are negative. So, this is his pre and post EKGs. So what is the next step? Should we do nothing, just continue to monitor the patient? Should we transfuse the patient? Should we do a stress myocardial perfusion imaging? Or should we refer the patient for a coronary angiography? We'll come to this point after. So now let's start. Definitions. What are we actually dealing with? Okay, what is perioperative injury, MI, MINS, all these terminology? So first of all, myocardial injury is defined as myocardial cell death, which is elevated troponins. Cool? All right, now you don't necessarily have to have any evidence, any symptom, any problem, you just have elevated troponin. This is myocardial injury. Now, myocardial infarction is myocardial injury, elevated troponins, plus some sort of a proof of ischemia, either symptoms, EKG changes, Q wave, imaging evidence, or on angiography. Then it becomes myocardial infarction. Now, of course, both myocardial injury and myocardial infarction correlates with worse outcome and elevated MACE. Also, both have higher 30-day mortality, whether it is an acute rise or even a chronic elevation, which we find sometimes in some of our chronic patients who have especially chronic kidney disease. So the presence of elevated cardiac enzymes, myocardial injury, is not an innocent factor. Then comes the two other steps. So basically, we have the concept of perioperative myocardial infarction or injury, PMI, and that is, elevated troponins for whatever reason. Then a subset of those is what we call myocardial injury after non-cardiac surgery, with the new term MINS. Now, perioperative myocardial infarction, PMI, includes other causes for troponin elevation, such as non-cardiac causes, pulmonary embolism, sepsis, or other cardiac causes such as heart failure and arrhythmias, while MINS is purely injury due to decreased blood flow and a type 1 or type 2 myocardial infarction. So this is the scientific MINS. But in the words of Saeed Saleh, Allah yarhamah, ya MINS means ya riggala bil-Ingilizi. All right, so the next one. So how did they define MINS? How they come up with this diagnosis? Actually, and the reason there is so many definitions of it is because there are different trials that went through it. So the biggest one is VISION MINS, which identify it as a troponin of elevation plus a delta or a very significant troponin elevation. There is also the basal PMI, which identified any elevation, but not necessarily due to the heart. There's also an AHA definition. Anyways, the gestalt of all of this, I don't want to take too much of your time, is this. If you're dealing with troponin T, high sensitivity troponin T, any elevation between 20 and 65 with a delta of 5 is considered MINS, or a total elevation above 65. And the troponin I say anything above 60. This is kind of the overall definition of myocardial injury in non-cardiac surgery. The pathophysiology of MINS is different. Some of it is due to systemic inflammation, which causes direct injury to the myocytes, and release autonomic dysfunction can be a reason, which could either irritate a pre-existing atheroma and make it unstable, or it could tip the balance of the myocardial oxygen and supply mismatch and cause it more ischemia, or it could be a direct baroreflex and direct stress from the afterload. But always remember these 4 things that can happen in surgery, which are all deleterious to the heart. Number 1, hypotension. Number 2, tachycardia. Number 3, hypoxia. And number 4, anemia. These 4 are very harmful for our heart and can increase the risk of MINS considerably. Is it an important problem? Yes. Actually, around 300 million adults undergo surgery. And out of those, 4.6 million have some sort of an ischemic myocardial injury. 3.3 have an infarct, which is clinically relevant. But pay attention, 2/3 of those are asymptomatic. And this is why maybe we should think of pre- and perioperative assessment of the troponins as a routine part, because there's a lot of patients who are going to have MINS or PMI and we don't pick them up. And out of those, around 1 million will die. And that is being correlated in multiple studies which we kind of come across where they cause, deleterious effects and poor outcomes. So why does it matter? So first question is, does it matter? And can we do anything about it? Sometimes if we check something but we can't do anything about it, there's no sense in doing. So number 1, yes, first of all, most of the MIs or most of the injuries happen within 48 hours. That's the period where there's a lot of shifts in the fluids, there's a lot of pain, there's a lot of ischemia, hypotension, tachycardia, all of those, which increases the risk. So picking up those patients can actually help and may provide opportunity to improve survival. Now, there are different ways to check troponins. Some of them, there's the troponin T versus the high sensitivity troponin T, and there's the high sensitivity troponin I versus high sensitivity troponin T. in one study, it showed that the troponin, high sensitivity troponin T, was slightly more sensitive than of course, the other one, which makes sense. That's pretty much straightforward. But with the I versus the T, also the PMI were picked up more with the high sensitivity T and troponin T. All right. Now I want to bring your attention to this very important trial. I always say, I know this lecture is sponsored by Roche, and I appreciate their support for the science and all that. But I always tell you guys, listen to literature. Don't listen to me. Don't listen to what everyone says. If there's evidence, that's what goes, what we should go by. So, vision study. Vision study is a well-designed study that they looked at, myocardial injury in non-cardiac surgery, and the definition was, as we spoke, 20 to 65 with a delta of 5 or above 65. The total incidence was around 18%. That is 1 in 5 had some sort of a myocardial injury. So it's not uncommon. That's number one. Number two, the mortality 30-day was 4.1. Again, not good. So it is important to pick up those patients, and especially if we can do something for them, we have to actually pay attention to that. And as you can see here, clearly the mortality, the cumulative hazard was higher the higher the troponin went. The second one was basal PMI. This is perioperative myocardial infarct or injury. The overall incidence, again, was around 16%. And if you can see here, there's some cardiac PMIs, which is 13.4, and a little bit of extracardiac. But again, regardless, cardiac or extracardiac, it correlated with worse mortality. The 30-day mortality was 10% overall, and the 1 year was for cardiac PMI was around 20%. Again, not good. So we have to pay attention. We have to pick up those patients. So it is important, and it does make a difference. If you pick it up, it does make a difference. And in this meta-analysis, or in the vision study, 93% of patients who had MINS did not experience ischemic symptoms. Again, this is a kind of a red flag that we should try to find a way to pick them up before symptoms, or maybe symptoms will never develop. So, and if you notice here in this slide, there's two things I want to bring to your attention. It is not just the fact that PMI happened or did not happen. So if the baseline was also elevated, correlated with worse prognosis. So the best thing is to have normal baseline and no PMI. But then comes a elevated baseline, but no PMI. The worst is having PMI and elevated baseline. Okay? All right. So I'm going to move forward here for the sake of time. Can we do anything about it? So that's the question. Is there something that we can treat? Yes, there are some things that we can do. There's the biggest two is aspirin and statin. POISE trial, POISE 2 especially, showed the following. Routine aspirin preoperatively not indicated. However, in patients who do have MINS or coronary artery disease, aspirin is useful. So that's number one. Number two, statins do help also for MINS because it makes the plaque more stable. On another kind of point or angle, the MANAGE trial showed maybe dabigatran is useful also to treat MINS and reduce the mortality of MINS, but this trial had some flaws in it. So that's why I only made it as a class 2B in the recommendations. All right, so which patients should be involved? Which patients should be screened? Which patients should we order this test on? Overall, if you have a patient who's going for an emergency surgery or a time-sensitive surgery, you have to go for the surgery and that's it, right? We're talking about more of elective patients, elective surgeries. Overall, the European, Canadians, Americans had different ways of putting it, but overall, if you have a patient who has coronary artery disease or some sort of atherosclerosis, if you have a high-risk patient, smoker, diabetic, kidney disease, strokes, or if you have a patient above 65, then probably you should order a high-sensitivity troponin on him preoperatively and at day 1 or day 2. This is the kind of the general message, most important part. We're going to talk about it in different ways, but that's the biggest one. This is a busy slide. I wanted to show you different risk stratification scores, but the easiest to use is actually revised cardiac index. The RCRI has less things. There's, of course, some online calculators that you could use. All right, moving on. Guideline recommendations. So, is this in real practice? Has this been actually recommended by guidelines, or is it just us looking at studies? And does it make a difference to actually change it? So yes, this has been going on for a while. The first society to suggest it was a Canadian in 2017, and it went on to include the anesthesia, and then the European, and then the American finally. And they've, as I said, they've defined it differently. This, I'm sorry, may not be projecting as well. But the overall message, again, because it's important, patients who are above 65, patients who are at cardiac risk and above 45, and patients who have established atherosclerosis. All right, this is the European guidelines, and the recommendation is to do it at day 1, which is 24 hours post-operatively, and or 48 hours. But it's also recommended kind of doing pre-operatively that level. Why? To see the delta. All right, so you can see if there's an increase or is it a chronic change. All right, so this is what we were talking about. First you take it pre-operatively, then you go through it, and I'm gonna move forward. Same thing for the American heart. They had the same kind of recommendations, but a little bit lower than the European. Now, this is what we talked about, the managed trial for the dabigatran as a potential solution, but it does have some flaws. That's why I only made it to 2B. Now, I like this flow chart in the PMI management. This is so, okay, we said we picked up PMI. The patient does have perioperative myocardial infarct. What are we going to do about it? So first of all, we're going to do initial assessment, which is 12 lead and history and hemoglobin. I will see, is there any STT changes? If there is, check if there's severe anemia that is reversible. If not, this is type 1 MI, and we have to manage as if it is an acute coronary syndrome. It's type 1. If it not, then we'll move next in line, which is potential a cardiac cause for MENS. The biggest ones are tachycardias and heart failure. So we check an NT-proBNP, we'll do an echo. If it is, we'll treat the cause. If not, we'll look for non-cardiac causes, which is the biggest two, sepsis and PE. So we'll do a D-dimer procalcitonin. If not, then we'll look again for anemia, and if it is low, below 8, then we should transfuse because this is type 2 MI. Otherwise, we should reevaluate, maybe it's some sort of a weird type 2 MI. This is the European flow chart, and I find it very useful and easy. The other ones are similar, but basically that's it. Okay, so in conclusion, basically, what are the steps? How are we going to approach our patient? What are we going to do? Number one, we're going to decide, is this an emergent surgery or elective? Emergent, done deal. Elective, then we're going to do a MDT. We're going to talk, we're going to evaluate the patient and see his risk. So if he's at risk, then we should do preoperative troponin assessment. Who are the patients at risk? Again, 65, above 65, 45 with risk factors or established disease. Then, if he's unstable, he's having active symptoms, he should go for a cardiologist, surgery should be postponed. If not, then we should try to risk stratify him overall, and this is the way. He used to do low, intermediate, high, but recent workup, recent perioperative assessment actually classified them into two major categories: low risk versus elevated risk. And if it's elevated risk, you go through the process. The critical point here is what? Even if we said the patient is kind of clear, not cleared, I hate to use the word clear for surgery. If he's okay for surgery, proceed to surgery. We should pay attention and take care of him during surgery. Basically, we should make sure he's not hypotensive, not tachycardic, not hypoxic, not anemic. Okay, always these four. Then the perioperative MI treatment, as we talked about afterwards. This is the ACC-AHA guidelines, similar, different wording. Going back to our patients for the sake of time. So he's a 73-year-old gentleman with a hiatal hernia who's undergoing fundal ligation. He does have risk factors, so he's more than 65. He has risk factors, almost coronary artery disease equivalent, although he's asymptomatic. So, first of all, his first set of troponin is not completely normal. 16 is kind of slightly elevated, more than 14, which is the cutoff for 99 percentile for this assay. 41 also elevated, and a delta more than 5%. So this is clearly a perioperative myocardial injury. Now, his hemoglobin is okay, so it's not the anemia. So if we're going to go by the flow chart, so we're looking for a potential type 1 here, because
He's anemic. He's anemic.
I know. He's anemic, but it's more than 8. So usually the guidelines will tell you to transfuse below 8. You would want to optimize his treatment, but yes, EKGs, of course, are remarkable. So out of these 4, which one would you probably go with? Probably this patient would benefit from a cardiology evaluation plus or minus coronary angiography, and he did have 3-vessel disease and needed revascularization. All right, I think I'm right on time. Thank you for your time, and if there's any questions, I'll be more than happy to answer.
شكرا دكتور قيس. Very informative and very educational. We have time for questions. نبلش بالكومنت أو أسئلة من البانelists.
Yes.
أسامة.
Dr. Ayman. Thank you very much, Dr. Ayman. I have some arguments.
سؤال لقيس ولا أيمن؟
أيمن.
محمودة.
أيمن حمودة, yes. في عندي بعض issues to argue about concerning the chronic coronary syndrome management اللي أنت عملت عليها محاضرة beautiful lecture. هلا في arguments جديدة عم تحكي على الديوريشن بالنسبة للبيتا blockers in stable coronary artery disease. وناس كانت تحكي إنه خلص خلال أشهر، لا خلال سنة، لا في ناس بقول لك life long. فالكلاسيكال كان زمان من وقت ما تعلمنا إنه it's life long. أعطيها وخلي الهارت ريت 55 to 60، وهذه كمان debatable issue صارت هالأيام من جديد، وبلشوا إنه can we give it to the patients just for a certain period of time or not? This is the number one issue. وفي من ضمن الcontroversial طبعا recent studies اللي عندنا الريتش والكلاريفاي وهدول studies. هلا الشغله الثانيه the second point about the vasospastic coronary syndromes بالذات Prince metals for example. كانت ناس تقول لك أنا if I give sometimes the beta blockers, so cardioselective beta blockers or not, it might worsen it. وأنا بفضل إنه نعطي calcium channel blockers بالvasospastic. فهذه كمان عشان to identify between the real macro or micro stenosis أو obstruction ولا عندنا vasospastic، وهذه بالنسبة لنا مهمة. The third point about the heart rate، وهو كلها ماشية في نفس السكوب. الهارت ريت كمان كان الحكي انه we need our patients to stay في الفيلد of 55 to 60. لا بعض الناس قال لك انه كل ما عم بنزل بعضهم بقول لك انا بحس بالتعب وعندي فاتيك وهايبوتنشن ومن هذا الكلام.
Thank you, Osama. So point number 1 is beta blocker for how long in chronic coronary syndrome?
Yes.
So we're talking about 1/3 of these patients, because if you take out the CCS with heart failure, where there is compelling indication for beta blockers, and then you again take probably another third with CCS and tachycardia, okay, so and hypertension. So we're talking about pure CCS without heart failure, no ejection fraction. Again, the data has, as you said, has been lingering on the benefit of beta blocker that we have been talking about for a long time is being titrated little bit with time, but still, I think our population is really different, because what drives some of the angina is the sympathetic tone. So most of the time, I think a good heart rate that can be tolerated with a good dose of beta blocker should be indicated. And when you look at the guidelines, you find that beta blockers or calcium channel blocker, quote, not reverse, not CC calcium channel blocker or beta blocker. So they put beta blockers first. So I think the beta blocker are the mainstay in treating these patients for many reasons. For the Prince metal angina, we have to differentiate between acute coronary syndrome, someone who's coming with coronary spasm with ST elevation, and then you discover that he has. We're talking about someone who you are not lucky to detect spasm on coronary angiography because he comes with angina and quote unquote the coronaries are normal, but you still suspect there is some element of spasm. Here comes the role of provoking the angina or the spasm with acetylcholine, which is usually a vasodilator, but in the presence of endothelial dysfunction, it is vasospastic, or some in German, like they use ergonovin. So in the old days, this was a no-no, it is very dangerous. But now still, if you have someone with real angina, textbook description of angina and normal coronaries, and you still want to know whether you start medication for antispasm or not, you can provoke it with acetylcholine easily. It is a 3-minute test. The medication goes away very fast. Complications are very, very low in the cath lab. So you still can provoke it and look at the ST depression once you inject the medication and or chest pain. شو النقطة الثالثة أسامة؟
Third point about the heart rate and the hypotension and the fatigue.
Yeah, again. Most of the time when you use beta blocker, of course, you have to avoid, especially in the elderly. Fatigued patient with borderline hypotension, you either cut on the dose, or if you find the medication is adequately okay, you can add ivabradin to give you more heart rate benefit.
Just one point على النقطة الأولى اللي حكيتها، إنه أنا بالنسبة لي إذا my patient has acute MI ولا عنده arrhythmias tachycardia ولا عنده heart failure ولا عنده hypertension، كل هدول compelling إنه to give beta blockers. بس if he's not، بمعنى آخر إنه هو خلص chronic coronary syndrome and no arrhythmias so far وما في عندي أي hypertension كل هذا الكلام، هون صار الديبيت في موضوع الافيكاسي of cardio-selective beta blockers على اللونج.
Yeah, I think based on the guidelines, Osama, I think beta blockers are the best medications to be used still.
For a long period.
In addition to antiplatelets and statin, of course.
اسمح لي يعطيك العافية. في لي سؤال لقيس وسؤال للدكتور عاصم. قيس, how do you differentiate between true perioperative myocardial infarction from myocardial injury due to non-ischemic issue, and should routinely post-operative high-sensitive troponin screening be implanted for high-risk patient in absence of the symptoms?
Yeah. Okay. Thank you for your question. So for the second one, it's easy. The indications for routine screening is age above 65, age above 45 with risk factors, and or established coronary artery disease or atherosclerosis. Yes, you should do it preoperatively and at day 1 and day 2. This is most of the guidelines would go with that. So that's the first question. For the second question was, how do you differentiate between perioperative myocardial infarction versus injury or non-cardiac?
Myocardial injury due to non-ischemic event.
Okay, so other causes basically. So both, this is not MENS, because MENS is injury due to type 1, type 2. This is, you're talking about PMI.
Yes.
With cardiac PMI versus non-cardiac PMI. History and physical, this is basically the way to go. So if there's anything that, the causes, the major causes of non-cardiac PMI are pulmonary embolism and sepsis. So those are the ones that you look for. And the cardiac ones, other than, of course, MENS, is anemia, tachyarrhythmias, heart failure, valvular disorder, and I said heart failure, right? And hypoxia. Okay.
Thank you.
Yes,
دكتور عاصم.
دكتور جعبري، معلش بالنسبه للموضوع سؤالك كثير مهم في موضوع التفريق بي ام اي والمنز.
Definitely.
وهلا انا ثانك يو فيري ماتش دكتور قيس على الليكتشر، لانه هذا فيري بوبيولار ناو ديبيتابل ايشو، لانه في ناس بقول لك احنا هذا له سبب وتقصير من عندنا في موضوع identifying the underlying pathophysiological status. يعني this is very important، لأن أنت عم بتدخل one of the patients for surgery, non-cardiac surgery، ومش معمول له good evaluation، هذه واحدة، وبعدين تكتشف إنه during this surgery صابوا hypotension، صابوا ischemia،
hypoxia،
صابوا hypoxia، صابوا anemia bleeding، ودخل في injury.
One of the
This is very important.
Very, very important. Actually, one of the commonest cause of MINS is actually intraoperative transit hypotension or hypoxia or
bleeding.
tachyarrhythmias. And actually, out of all, do you remember we were talking about how to treat, when we said aspirin, statins, and all that? The best way to prevent and treat is to actually avoid these things.
Yes.
An operation.
So good evaluation يعني before. Second thing about the analgesia and anesthesia. ما هي كمان it masks
which masks
a lot of
symptoms.
problems with symptoms يعني analgesia and anesthesia.
But and that's why we should routinely look for them. We're not used to that, but this is a new trend. We should do them, especially in higher risk patients. Maybe not for every single younger patient coming in, like 20-year-old coming in for appendix, maybe. But you know, there are certain people that we should. Okay.
خليني اسالك قيس، احنا هذيك مره كان في عندنا جمعيه القلب موضوع البريوبراتيف اسسمنت.
Yes.
الدكتور ايمن دكتور محمود they wrote the recommendation. كان في تروبونين recommendation فيها؟ وتز يعني هلا
It's consistent with
حتصير يعني قانون؟
هي مش قانون.
High risk.
It's more of a guidelines. Have you ever watched Pirates of Caribbean? Yeah, so there is Jack Sparrow when he brings the guidelines and he's put them and it's more of like a guidelines.
دكتور إياس especially
سعيد
for
صالح على Pirates of the Caribbean. أنا مش عارف شو وضعك اليوم.
دكتور إياس especially for high risk in absence of the
I agree.
سؤالي أخير للدكتور عاصم. دكتور عاصم, how do you approach lipid management in a patient with recurrent event in spite of reaching the target LDL?
If you بصراحة control all the risk factors, diabetes, hypertension, anti-anginal treatments, you will not drop the risk to zero. دائما في residual risk, راح يضل في residual risk. I don't know if you can help him with يعني lifestyle modification on top of them. ابو بي 100 ابو بي 100 خليني احكي لك على قصه الابو بي 100 ما دام فتحنا الموضوع. هسه الجايد لاينز ستيل ريكومند ال LDL levels. ابو بي 100 drugs which reduce ابو بي 100 ما عندك الا البي سي اس كي 9 inhibitors وريسنتلي ايزيتامايب وبامبودويك اسيد. هذول اثنين they reduce. بس قديش الريدكشن تبع البي سي اس كي 9 inhibitors مع الابو بي 100؟ 30% maximum يعني maximum reduction of ابو بي 100 مع البي سي اس كي 9 inhibitors هي 30%. ف it is not the only risk factor. if you control you will drop the events. في other factors بعدين يعني مثلا عندك مثلا الان في توكس على اللايبوبروتين سمول اي. بس شو بدنا what we can do مثلا فيش drugs they lower the lipoprotein small a. يمكن الهرمون اللي عند النساء استروجين بينزل الابو بيتا اللي بينزل اللايبوبروتين سمول اي والبي سي اس كي 9 بينزلوا شوي حوالي 20% اللايبوبروتين سمول اي. بس في dedicated drugs being developed الان في definite يمكن 5 أو 6 drugs dedicated for reduction of lipoprotein small a. لكن برغم having said that اعتقد ان الانتي ليبيدز they are complementary to each other. مثلا البي سي اس كي 9 انهبيترز واللي هو بينزل 60% ما له اي افكت على السي ار بي نهائيا. زيرو افكت على السي ار بي. طيب الستاتينز والبليوتروبيك افكتس هم الموست بوتنت يعني الرجوفا والاتورفا ان بارتيكولار هم الموست بوتنت lowering of the CRB. فاحنا ستيل يعني الجايد لاينز هي recommended to follow LDL. Can you measure the Abu Beta 100? You can measure it بس يعني ما حيغير شيء معك في التريتمنت.
أنا أعتقد سمحت لي على كومنت. إحنا أعتقد أي discussion beyond the LDL will only function to dilute الفوكس تبعنا. already failing miserably من controlling the LDL. فأعتقد أي شيء ثاني is of academic interest. البيريت الA والأبو ما أعرف قديش 100. بس أعتقد إحنا we're failing hugely بcontrolling the LDL. ولازم التوجه العام والجايد لاينز يكونوا دائما LDL has to be decreased. بعدين بنصير نروح على fine tuning of other things of drugs that are probably less available ويمكن costly وقصص زي هيك. Let's get the LDL down وبعدين نروح على
yes,
other.
The LDL is the cornerstone.
Other comments?
Yes, thank you. يعني لا سؤاله كان واضح لدكتور محمد انه انا يعني عم بياخذ قاعد دوزز عاليه جدا ووصلت لمرحله انه في عنده ريكارنت ايفنتس، فهذا بدك تشوف الاشياء الثانيه، جين ستدي، بدك تدخل كمان، انسى البي سي اس كي 9 والبنبيدويك اسيد وكل هذا الكلام. You go sometimes for a stronger antiplatelets, sometimes you go for anticoagulants، وفي اشياء اخرى. فكل الكوموربيديتيز اللي حكى عنها الدكتور عاصم yes we want to deal with. Thank you.
I think we have to make sure that the patient is compliant too. The only thing that we can do for such patient is to achieve the target of less than LDL target of less than 40, and to make sure that he's not smoking, he's compliant with medication, etc. We don't follow LPA or ApoB 100.
May I have a question?
Okay.
Dr. Qais, we all face this problem. If you work in a busy hospital every now and then, somebody will call you, say, we have a troponin elevated, it's a post-operatively patient, and you have. What's your threshold to go invasively? And do you recommend all those patients to go non-invasively after discharge or not? We all understand the guidelines. This is a minor leak. Follow up the patient for a couple days. See the troponin. If you don't have any high risk features, you give them all the medication. So the question, and those patients are full with cardiac risk factors. When and if you recommend for all those patients to be screened later on, either invasively or non-invasively. Thank you.
Thank you. Your question is very important. And actually, medicine is an art. And there is no one answer that's going to fit everything. Definitely, you're not going to take all your patients to the cath lab. Actually, sometimes we know, all of us, if a patient sneezes hard enough, he's probably going to have a troponin elevation. So be careful. But so no, not every troponin elevation we're going to take to the cath lab. No, that's not the message I want to give for sure. What we need to do is, the message I wanted to give is, first of all, you might have troponin elevation without knowing, so you need to check first. The second one, every troponin elevation is clinically significant, meaning it increases the risk. Now, once that red flag goes up, I need to see what's going on. What is behind that and how serious it is. One of them is cardiac causes, some of them are non-cardiac causes. Out of the cardiac causes, some of them are coronary atherosclerotic, some of them are not. Even the atherosclerotic, some of them are type 1 and type 2. Type 2 are demand supply, you fix the demand, that's where you need to go. The only ones you're going to consider to take to the cath lab are the significant type 1 MIs, and you're going to go by the trend of the troponin. How high it climbs, how much, symptoms, other evidence of ischemia, meaning wall motion abnormalities, stress testing maybe, EKG changes. So, you're going to build a clinical picture. I cannot tell you, every single patient you're going to, no, that's wrong. So it has to go by the clinical picture, and those are the patients that I'm going to take to the cath lab, especially if they are high risk. I hope I answered your question. All right, thank you.
Usually I recommend it after a couple of months, do stress or perfusion images to make sure that your coronary is in a good condition.
Yes, and MPI is a very useful tool, by the way. And MPI, always think of MPI, myocardial perfusion imaging, scintigraphy, as just for diagnosis. But as a matter of fact, it's an excellent tool for prognosis. Because if my ischemia is small or minimal, even if he has coronary artery disease, it's not worrisome.
Yeah.
Thanks.
Qais, can I have a small question, please?
Yes, go ahead.
Thank you, Qais. Excellent wording.
Thank you.
I've been here since 2009, and I think we are hearing some schizophrenic messages here. So people with risks going for any non-cardiac surgery, we need to check troponin per guidelines. At the same token, people are going for angioplasty, and next day 90% of the people in this room, they do not check the troponins.
So pre-operative قيس يعني هذا highlight the pre-operative assessment.
Yes. Okay. So technically, yes, you should check post-procedural troponins. Now there's some debate, but yes, it's preferable. Why? Because also post-procedural elevation of troponin correlates with poor prognosis. The higher it goes, it's expected, but the higher it goes, the worse. That's number one. The second, the universal definitions of MI. Type 1, we all talked about it. Type 2, demand. Type 3, pathological. Type 4 is post-procedural PCI. So that's an MI, especially if it goes 5 times above the upper normal limit of the 99%. So then this is an MI. This is something serious. We need to see why this has happened. So if we want to talk science, it's preferable to do it. But unfortunately, due to maybe economic constraints and trying to cut down on costs, it's not a standard of care here. But yes, it's a good practice if you want to do it.
طب بس انا اعلق على الموضوع. موضوع انه سكيزوفرينيك ما هو what you gonna do اذا لقيت asymptomatic post PCI patient has a troponin of double the normal.
Double, nothing. Five times. 5 times the upper limit of normal. That's a post-procedural MI. So I need to look. I need to see clinically how is he doing.
No symptoms.
Maybe sometimes there is something to explain. Maybe I've jailed a lesion and I know that's the reason. So at that point, it's less problematic. I should do EKGs. I should do maybe an echo to see for wall motion abnormalities. And if my suspicion is so high, I might even consider going back in, which is a low threshold, but it can. So, but that's how it should. It's not expected to have regularly more than 5 times upper elevation of your troponins, unless you have a clear slow flow, no reflow, a gelled, vessel or something like that.
Allow me just 1 minute, please, if the chairperson and please just 1 minute. The question which Dr. Raed asked is a very legible question, regardless of how he put it in words. It's a very legible question. I personally, إذا في حدا من الCCU بيشتغل معي قاعدين بيعرفوا. It's routine for me in the past 30 years of practice in Jordan that I have a next morning CPK and CPK-MB. إذا حدا قاعد هون بعرف إنه أنا بكتب هذا كل يوم. Why do I do that? You can order high sensitivity troponin, but the caution is you have to have a baseline high sensitivity troponin to compare to. So if you don't have it, don't order it. What is the value of CK and CK, especially the MB next morning? It is already established, guys. It's not something for controversial discussion. If you get more than 10 times rise of the CPK, MB fraction going up the next morning, you treat your patient as a non-STEMI after PCI. So instead of discharging the patient, you maximize the treatment, you keep them under monitoring for another 24, 48 hours. And as Qais said, it tells you that there are more MACEs coming up, especially in the first 6 months. But allow me just to say that it's already established. It's not something but a lot of people don't do it. I do it personally, to be frank with you. I do it. Thank you.
Thank you.
Okay, we'll move to the next session. شكرا لكم جميعا. We'll move to the next session.